in.
Yeah, nice.
Oh, great.
Yeah.
Okay.
Thank you, Dr. Chitra and Dr. Srinivas, for involving me in this meeting, which has gone on so well today. The art of patient counseling in vitreoretinal surgery. Now, during the COVID times, in the first episode of COVID, when I was sitting idle, I just wrote I jotted a poem about the travails that we as vitreoretinal surgeons have to undergo. And I just picked out 2 stanzas from that, entailing long, elaborate workup for diagnosis and arduous, detailed counseling about prognosis between anatomic and visual outcomes, many times no anastomosis, the vitreoretinal surgeon and his patients in a difficult symbiosis. Surgical tinkering involves hours of backbreaking work, the capricious retina prone to again go berserk, leaving both patient and doctor in total murk, necessitating yet again a taxing, messy rework. So the retina is a most unforgiving tissue, and we must all be aware of many of these quotes that many of our ancestors have given, particularly the one by William Osler, that medicine is not an exact science. It's a science of uncertainty and an art of probability, and whether the patient will succeed or whether will succumb is really hard to say. Given this backdrop of medicine being an inexact science, we also have to be aware of Murphy's law and always expect the unexpected. As surgeons, we are expected to be confident, optimistic, but well, that is a given. We must always blend our optimism with realism. And somebody described surgery itself as trauma by appointment, tongue in cheek. And the term doctor comes from docere, Latin, which means to teach or a scholar. So we must not hide under our surgical brilliance and give the counseling a go-by. So counseling really is the art of tightrope walking. If you have to give an analogy, the fine art of being economical with the truth without telling lies, or the art of pleasing your wife without risking spending money. Apologies to all the wives here. The counseling itself is advice or guidance given for personal, social, or psychological problems. It really is the foundation of a doctor-patient symbiosis. And as has already been very elegantly told by Dr. Mahesh, it's not dealing with a tissue pathology, but a person who has a certain tissue pathology. It's essential for ethical, moral, and medico-legal reasons. And we must also remind ourselves constantly that the patient really is the center of the medical universe, around whom all our works revolve and towards which all our efforts should tend. It's a purposeful discussion to facilitate decision-making in the end. It may involve an individual, a family, or a group. And the goal being to convert a non-acceptor of care to acceptor of care. And we must have build our own counseling game. The critical question to answer is, do we really want to retain the patient? Patient selection is very crucial, particularly if you are a one-man army, one-eyed patients, very poor prognosis, high expectations, high-strung individuals, and then the level of technical or professional expertise that is at our disposal, etc. These are the things that should drive our counseling. It's important in such cases to document all details of counseling, and informed consent is what we should obtain and not an extorted consent. Here we can give the example of an oil lamp and an oil being replenished. You can tell the patient that the eye there is like an oil lamp with the oil mostly burnt up and the lamp about to be extinguished, and you're only trying to replenish some oil to keep that oil lamp burning longer. And in the very act of replenishing the oil, the lamp may go off, but the intent is what is important in such cases. So all these things can be explained by analogies. And the greatest trouble with communication is the illusion that it has taken place. So we would many times feel that we have got our message across to the patient, when in fact the patient may not have understood anything. And we should also be alert to the non-verbal communication that's happening. So counseling can involve either the preoperative, intraoperative, or the postoperative courses. We will largely limit our discussion to preoperative counseling. What we have to remember is not just passing on the information to the patient, but it's a dialogue with the counselor as the primary speaker. And this really, the art of counseling is the Achilles heel. It's not taught in our medical schools. There is a steep learning curve. It's hard to master and learn. And the goal would be to act as a facilitator or a partner or an enabler in the patient's decision-making, not a coaxer or an influencer. We should never attempt to talk or trick the patient into surgery during the course of our counseling. As I was preparing for this talk, I was watching the cricket match, and then I realized there is a lot of similarity between cricket and vitreoretinal surgery as well. Both are games of glorious uncertainties, and what we should what we should be doing is let the patient be the third umpire. After all, the patient is the owner of his eyeball, and he has every right to be the final arbiter. We must respect patient autonomy and also the basic human right to self-determination. And as far as we are concerned in counseling, we must always do the right thing. Coming to the counseling methods themselves, they have been ritualistically labeled as preparing for the counseling, the opening statement that you make, the content really, which is the kernel of the whole discussion, and closing the session. It should be as short as possible, yet as detailed as necessary. This may sound like an oxymoron, but that's how we must develop the skill of doing this. It's something like the précis writing, where you have all the details there, yet it is not too long and long winding or verbose. So 3 C's: clear, concise, cogent, and convincing. We must avoid frills or anything extras, and not to bombard the patient with medical jargon, or not to dazzle the patient with our so-called wordy brilliance. Coming to the essential elements, the risk-benefit ratio is what we should be concerned with. That is the cardinal factor. If functional loss is already present in the patient, it's a lot easier to counsel, whereas it can be tricky if the procedure is a prophylactic procedure, when the patient, merely because of our intervention, may have more problems. So we have to be very careful. Younger counselors, doctors who have just passed out, the newbies who are still wet behind the ears, they may counsel with textbook details, matter-of-fact details being given. That may sound a little alarmist. Or we have the other end of the spectrum. They may be economical with the truth, or tempt the patient with a one-sided discourse. Both of these are not preferable. The same message ought to be conveyed in a manner, expressed in a manner which is couched in appropriate language. Basically tell them about the natural history of the disease versus the course that is likely to happen after intervention. Now we have to make a fine distinction between selling and counseling. Are we trying to sell anything? No, that's really the work of a trader. We are not trying to sell anything. And here we must pay attention to the speech, the cadence, the inflection in our voice, etc. And somebody said the niceties of speech immeasurably outstrip the repertoire of even the most expressive face. We are also not indulging in marriage negotiations where pluses are highlighted and the minuses are only given in small print. So practical considerations. Solo versus institutional practice: use discretion always when you're in solo practice. No commercial considerations. Don't prompt the patient to have a second opinion. Always under promise and over deliver. Slightly pessimistic is the way to go about it. If you have decided to try and retain the patient, use of analogies is very helpful. Showing preoperative and postoperative pictures of similar nature will help. Wearing a smile always will definitely ease the discussion. And drawing boards with pros and cons column can be used. You can have another lady, because they say if you have a trained lady there, a doctor talks to the patient, but a counselor talks with the patient. So put the patient at ease with your words, facial language, hand gestures, tactful handling of queries, etc. Acknowledging family members is very important. You may be discussing with the patients, but the family members may feel offended because you didn't even acknowledge them, and they may say, we shall not go to this doctor. So acknowledging family members is equally important. Positive affirmations and interaction with other happy patients are other tools. Coming to the counseling aids, model eyes are not just desirable, but they are absolutely indispensable, because the patient may not know anything about the eye, how the eye functions. Using fundus photographs, FFA, OCTs are really very, very helpful. 3D animations if available, surgical videos, analogies from real life scenarios. Avoid quoting figures is another thing that I would like to highlight. Rather than saying 1 in 100, you try to have details about various real life scenarios which have a similar risk ratio, and you can say that the risk of anything happening is like the risk of having a problem with an air crash or a train derailment, etc. Again, using visual acuity limitations, and I will operate only before if it is less than 20/40. Again, is not the right way to go about it. You have to look at the patient as a whole. And success percentages is another thing. It's almost like a gamble or an auction. So one person says, I'll give you 40% vision. The other person says 60%. So we are going, and the highest bidder gets the patient. So that is not really the way to go about it. You have to tell them that you really don't know what percentage is likely to result, and that you will just have to go ahead with the surgery based on the information available. These are some of the counseling skills. A difference between guidance and counseling: intellectual details are given in guidance, whereas it's more the emotional aspects that are attended to in counseling. Just a sample of the analogies. I have 2-3 more slides. Now, if the patient asks about likely visual regain, you have to say it's like putting out the fire. We have a fire on our hand. The job is to put out the fire, and whatever remains at the end is the residual visual regain. So we really wouldn't be knowing what the visual regain would be.
Or if the patient, Dr. Kumar.
Yeah, these are some of the analogies, and which eye to operate is again the issue. Better eye first for the various reasons that I have stated there. So benefits of counseling: mutually pleasant doctor-patient relationship based on trust versus a tense situation. It's directly proportional to the complexity of the case and decreases patient anxiety and improved improved outcomes. It's always better to be open yet discreet. It's an art to master, as I said. And I will conclude with this by saying that if we consider product and byproduct, which is used in industrial language, the product really is the counseling and the byproduct is the retention of the patient. If after all your efforts, the patient decides not to get operated, then you have the right to work, but never to the fruit of the work. You should never engage in action for the sake of reward, nor should you long for inaction, that is improper counseling, which is what Krishna said in Bhagavad Gita. Thanks a lot. And sorry for the slight extension in time.
Thanks a lot, Dr. Kumar. Always like your play of words too, along with the content.